Could breathing through your mouth cause LPR symptoms? We're about to find out right now.
It's time for the Gerd Talk podcast with your host, health advocate, author, and researcher, Stu Sang. Your resource for healing acid reflux naturally. Stu Sang is the founder of GerdWise.com, a health website with the latest GERD research, GERD news, and natural reflux treatments. Now here's your host, Stu Sang.
Hey everybody, this is Stu Sang. Welcome to Gerd Talk, a podcast where we discuss all things GERD and where we focus on natural ways to treat acid reflux. I am your host, Stu Sang. Once again, thank you so much for tuning in. Welcome to the podcast. And on this episode of Gerd Talk, we'll be discussing mouth breathing. I'll be having a special guest, Dr. Seaman, who will be telling us all about mouth breathing, and we'll be discussing that. But before our interview with Dr. Seaman, just want to give you guys a quick update on GERDwise, my blog. Most of you guys, or a lot of you guys, frequent visitors, probably have noticed that I haven't been updating my blog as frequently as I used to. And the reason for that is because I am currently working on a program about treating acid reflux naturally. It's been a long time coming, but a lot of research has been done, and I've poured a lot of time into it. I'm very excited that it should be launching in the near future soon, but I'm currently working on that, and that's the reason why I haven't been able to update the site as much as I'd like to, so please forgive me for that. But I do plan on giving out my program for free to my early subscribers, so it's looking like the first 100 or 200 right now. But for updates on my program on acid reflux, you can subscribe to my email list and find out more about that. Okay, so on today's podcast, we'll be discussing mouth breathing and how it can actually be linked to acid reflux. And as a matter of fact, I know for a fact that many people who have LPR and sore throat, they're breathing through their mouths and they don't even know it. And breathing through their mouths, breathing through your mouth is one of the reasons why you can end up with a sore throat and even LPR symptoms, especially in the morning. And this topic is really near and dear to my heart because mouth breathing for me was one of the main reasons why I was developing LPR symptoms, and why, every morning I'd wake up, I'd get a dry mouth and a dry throat, and I had a sore throat. And this went on for years, and it got so bad. For those of you who know my story, you already know this, but it got so bad for me that I couldn't talk. I basically lost my voice for about 2 to 3 years. I got it back towards the tail end of the third year, but it was just a horrific experience. I mean, my voice would literally sound like this. Like, it would just be like this croak, like right there. And, even some days I couldn't even get that croak out. So I'm really passionate about this. Again, I just from talking to different people and listening to their stories, I have no doubt that many people who have a sore throat and dry mouth are mouth breathing. They don't know it because they're asleep, and that's why when they wake up, they have a sore throat and they have a dry mouth. And it's because the saliva in their throats are drying out, and there's nothing to lubricate their throat. And so if you get an acid reflux attack on top of that, then it's going to cause even more damage. And it's also one of the reasons why your throat won't heal. It's because it's not lubricated with saliva, which has been described as the natural anti-reflux barrier. But without further ado, I'd like to introduce my special guest, Dr. Seaman, who will be talking to us more about that. But first, a little intro on Dr. Seaman. He's a prosthodontist, one of the top prosthodontists in Colorado Springs. For those of you who don't know what a prosthodontist is a dentist who is completed dental school plus 3 years of advanced training typically. They specialize in treating and handling dental and facial problems. So you're talking about restoring missing teeth, jaw structures. So they're highly trained in cosmetics, implants, crowns, etc. Dr. Seaman received his undergraduate degree from the United States Military Academy at West Point. He also spent 2 years in the Air Force as a chemical engineer before attending the University of the Pacific Dental School in San Francisco, where he received his DDS degree in 1975. Dr. Seaman continued his education with 1 year of general practice residency, followed by a 3-year prosthodontics residency. He's presently a consultant to the Colorado State Board. Dr. Seaman has over 40 years of dentistry experience and currently practices in Silverthorne, Colorado. Dr. Seaman, thank you so much for joining us today on Gerd Talk.
Well, thank you, Stu. Thank you for having me.
It's my pleasure. So I actually found out about you through a YouTube video that Dr. Mike Mew put out, and you guys were actually talking about a product you created called LipSeal. And what really interested me was, and really fascinated me, was when you were talking about how mouth breathing dries out the mucosal tissue and can lead to a dry mouth and dry throat. And I was really interested in this because, like I was saying before, this was exactly my issue. And I had gone to a couple ENTs, and none of them told me that mouth breathing could cause acid reflux symptoms. I mean, none of them told me that when you breathe through your mouth, it could dry out your throat and cause LPR symptoms. None of them. And so when I found you, Dr. Seaman, and I listened to your interview with Dr. Mew, I was relieved. But for my listeners out there who maybe this is their first time discovering or even hearing about mouth breathing, can you tell us what mouth breathing is and why it's bad?
Well, of course. Mouth breathing is really something we can do with conscious effort anytime we want. It's one of the two routes of breathing, nose or mouth. And once it becomes more of a habit and you do it without knowing it in longer periods of time, then it creates some problems, especially with the mucosal tissue. It's such a fragile, very, very important tissue that lines the entire respiratory system. The mouth, the airway, the upper nose, and the lungs also are all lined by mucosal tissue. And primarily it's the dysfunction that occurs from mouth breathing with drying out, desiccating this mucosal tissue. It thrives in a very aqueous, wet environment. And there's a reason for that. I can get into it chemically briefly here, but once it is allowed to dry out, it changes character and becomes very swollen, inflamed, collects bacteria like flypaper, and also changes into a sticky substance. And so, it's no wonder that the airway, tissues of the airway and mouth and nose start to cling together once they get dry. You can time it, if you start mouth breathing after normal breathing, for about a minute, then your nose becomes congested. And it's just the mucosal tissue up in the upper nose that begins to swell and stick to each other and become congested. One side effect, major side effect problem of that is that it shuts down the sinus portal drainage. And then we start losing important mucosal substance that's produced in the sinuses. The sinuses really produce about 1 to 1.5 liters of mucus a day. And so they're just a drip machine, and they're just there to primarily keep the mucosal tissue of the whole respiratory system moist. And once the portals get clogged up with nasal congestion, the problem only just starts to begin. Mucosal tissue chemically possesses a mucopolysaccharide, a complex sugar molecule that by name it's hexosamine, and it behaves like any sugar. Once it's allowed to dry out, if you make your own simple syrup, it's a mixture of sugar and warm water dissolved. And if you put your finger in the simple syrup, you pull your finger out and it becomes very tacky, sticky to touch. And that's what's happening with the mucosal tissue hexosamine substance. as it is allowed to dry out, it becomes sticky, just like your fingers get tacky and stick together. Your airway's doing that also. Your mouth, you get cotton mouth. And number one, big problem. Number two, it collects bacteria. In the mouth, this leads to bacterial clinging to the gingival tissue in the tongue and the oral cheek tissue, and they get swollen and inflamed, and retains the bacteria. It increases plaque count and leads to higher incidences of dental decay and periodontal disease, as well as mouth sores in general. That's all from the mucosal tissue being allowed to dry out and starting to accumulate what I call a bacterial load. That they're not. It changes their overall physiology and causes breakdown. Really, the mouth breaks down due to two basic reasons: bacteria and mechanics. Those two, and mouth breathing also promotes the mechanical breakdown. I got into learning about breathing and sleep apnea when about 15 years ago or so. Sleep bruxism was associated with breathing problems, obstructive sleep apnea during sleep. And there's an 80% probability of occurrence of grinding of the teeth, really excitation of the jaw muscles of mastication, every time you have a breathing interruption. And it can be as simple as minor clinging of the side walls of the airway tissue, or snoring. That's a minor form of a mild obstructive sleep apnea, all the way into gasping and not being able to breathe. And so it's a full range, but the same brain control effect takes over when you're subconscious in a sleep. The brain tries to keep you alive and make you breathe. And so it's called a sleep arousal. And part of the overall reactions of that are a release of cortisol, increase of sympathetic nervous activity, increase of cardiac activity, and trying to get the body ready for fight or flight response. Also, part of this 4-second window of time of an arousal, there are extra jaw clenching muscle activities and clenching muscles activity, which cause the body's trying to open the airway, and it does that like basic CPR. You protrude, pull the jaw forward, pull the tongue out of the airway, and the brain does that, and it just doesn't know quite how hard or soft, and so it goes to town, and you get a lot of muscle activity while you're asleep. We call it bruxing or clenching, grinding of your teeth during sleep, and it wears teeth and breaks teeth and causes a lot of tooth damage and joint soreness and damage and muscle tenderness. And so that's what we kind of treat as a mechanical deterioration of the mouth. And so mouth breathing is really associated with both of those entities, dry mucosal tissue and extra sleep bruxism activity. And boy, if we could get in my business, I'm a prosthodontist, and so I treat complex cases. I try to restore function and comfort and appearance and health to my patients. And so they're all there as chronic dental need patients, and they're always continually breaking down. And I've always treated them from the mechanical model through my training for many years, until I discovered I went to a sleep apnea course for dentists to get involved with making their dental appliances, which pull the jaw forward during sleep, a mandibular advancement appliance. And they're very effective with keeping the tongue propped forward, which keeps the airway more open. It doesn't do much with stopping mouth breathing or the drying effect, but it mechanically drags the tongue out of the airway. So I got involved with studying that 7-8 years ago, and seeing what I could do with helping my patients in that regard. And I made some, and I wasn't thrilled with some of the side effects that my patients were experiencing with them, and so I was looking for other means. I asked, okay, if this appliance pulls the tongue out of the airway, I ask the question, what's wrong with the tongue? And there are not too many answers coming forth, and so I have to kind of look into it myself, that the tongue has really assumed a low tongue position in the mouth. One of the things we screen for as dentists for sleep apnea are indentations along the border of the tongue, and that's just an indication that the tongue is laying low in the mouth and picking up the indentations of the side posterior teeth, and in that it's not maintaining a palatal position anymore. And then we get into the reasons why, and your article on mouth breathing covered this very well. I enjoyed reading that, and it was all right on target on everything that you said in that. So the tongue begins, as you reviewed, and most people know, it resting on the palate, and that's how the whole animal kingdom functions, with breathing through the nose and the tongue on the palate. Basically, the tongue is primarily involved with both mastication, chewing, and also swallowing, and so those are its two primary, speech also. So with chewing, with the advent of softer diets in the Western civilization, they postulate that there was less functional need of the tongue to assist with chewing, mastication of the food, and so it lost its role in chewing, and so it was permitted to then relax a bit and just lay flatter, and it lost its muscle tone to the suspension muscles of the tongue, which prop and hold the tongue up, and then it started to assume a down and back into the airway position, and that led to all kinds of breathing problems at nighttime for people.
Mm-hmm.
And
yeah,
go ahead.
And this is all, I mean, it's so fascinating to me because it seems, you just mentioned a list of conditions that's associated with mouth breathing, and I talk to people with acid reflux, and it seems they have these same conditions. They ask me different questions and ask about my story, but I've always noticed that there are a great deal of people who have acid reflux that also have cavities, sleep apnea, bruxism, something you mentioned already, grinding of the teeth.
It all goes together.
Yeah. And so I step back and I take a look at this whole picture and I say to myself, there has to be a connection between all these symptoms, and it seems to be mouth breathing. At least that seems to be a big contributor. But something else I want to cover before we go into some questions about the positioning of the tongue, love to ask you about that, is one of the more, I guess, unbelievable things when you hear about it. You're like, is this really true? This is crazy. And that is mouth breathing can actually change the facial growth of a child.
Oh, yeah.
And can actually mess with your teeth. Can you explain how this happens? And I know orthotropics is something Dr. Mew has that sort of expertise, but you visited him, you're friends with him, but I'm sure you know a great deal about that. Can you tell us how mouth breathing changes facial growth and the positioning of the teeth?
Okay, great question. And the connection is the mouth breathing event and the tongue position. And they go together. And so once the tongue relaxes in the mouth, and then coincidentally or otherwise, the child gets a congestion, a cold, upper respiratory infection, and they're forced to breathe through the mouth to get through that until the nose is cleared up, and then they assume this new norm, status quo position of breathing through the mouth, which has to be on top of the tongue. So the tongue is forced lower to breathe over the top of it with the jaw hanging over. So mouth breathing and tongue position go hand in hand, and both of them lead to problems in the mouth with the low tongue position now, and you swallow, one swallows about 1,000 times a day, and it doesn't have the palatal bone to brace on, so it can plunge the food backwards into the throat, and so it's just a free-ended muscle, the tip of the tongue, and acts like a snake. When it contracts, it pulls forward. And so then it's called tongue thrusting, which then put lateral and forward pressure on the teeth. In fact, they've measured the pressure that the tongue exerts during a tongue thrusting episode, and it's 500 grams of pressure. Orthodontic pressure, traditional orthodontic braces, is 100 grams of pressure necessary to move a teeth. And so 1,000 times a day, your teeth are receiving excessive forces which cause them to move. And so we get anterior open bite, where the front teeth can't touch anymore because the tongue kind of works its way between them and forces them to be open.
Mm-hmm. And my understanding is all of these things like tongue thrusting causes the face, the mandible and the maxilla to swing down and for the overall face to grow downwards.
Right. What it does, it narrows the arch. We're not getting lateral pressures on the upper posterior teeth, and so they don't get full arch width. And which during the primary ages of development of the palate and then later calcification of it, that begins age 4 or 5, extending through 7, 8, 9 time frame. And so if the tongue didn't serve its purpose about the age of 4 to expand the arch width, then the lower jaw kind of follows this narrow arch as the upper molars are closer together. The palate arches up, and so it develops a very high-pitched palate vault, and then that's robbing from the other structure right opposite the palate bone, and that's the nose, the floor of the nose. And so we start to alter the whole facial structure growth of the mid face of the upper palate area in growth. It becomes narrow and it grows up toward the nose and robs some of the space there. And then the lower jaw kind of follows form and becomes narrow and grows down. We call it down and forward growth. And so if you let that go on with the normal or abnormal tongue function at that point in time, then you got to go and do corrective therapy. And I ask orthodontists all the time, conventional U.S. orthodontists, okay, what do you have an orthodontic patient who went through all of this development, and now you're going to try to correct them. And what do you do about mouth breathing? And what do you do about tongue thrusting? And they just all of them collectively shake their head and say, I don't know. I'm aware of it, but I don't know what to do about it. And so that's the real sad part about it all. And so they rush in and do their corrective therapy, and then the patient has relapse. The tongue is still acting abnormally and moving the teeth around again, and the mouth breathing and the dry gingival tissue. And so the problem never gets fixed. And a lot of my elderly patients in my practice have been through sets of orthodontic therapies for 3 times in their life because of what they call relapse. They just accept relapse as a normal occurrence. It's there because of the tongue. And the lips they lose their muscle tone to help hold the teeth in proper muscle balance. The teeth fit between the lips and the cheeks, and also the tongue, inside and outside, forming a little muscular trough for the teeth. The rest in a very normal situation like that.
Mm-hmm. And so what you're saying is when the tongue is not, sucked to the roof of the mouth and drops to the floor of the mouth, the face grows downward, and the overall effect, and I'll try to post some pictures in our blog post, maybe we can use a few of Dr. Mew's, but the overall effect on the face, especially of a young boy or girl, is that the lower jaw appears to go in, and tends to make the nose look bigger, and I guess just make the face overall look, I don't want to say uglier, but like if they were to have a proper tongue position, the face would look much better. yeah. So
100%.
yeah, and that's, I mean, again, that's fascinating. And Dr. Mike Mew also has a couple of YouTube videos talking about how he took a look at all the attractive faces, at least in the U.S. today, of different celebrities, and noticed that all attractive faces, almost all of them, they'll have forward growth, and that lower jaw will grow forward.
Right.
And so, yeah, that's a very interesting thing, and maybe we'll have some pictures below so people can actually get a visual to see what we're talking about here. I'd like to ask you a question about acid reflux. You must see, tons of patients in your career. Have any of your patients, in your experience, have issues with acid reflux? Do you get that a lot? What has your experience been with that?
My patient base primarily gets to me because they have breakdown with bacteria and or grinding, and so they all have this commonality of problems, and it all relates to mouth breathing. And acid reflux and GERD is a very common complaint on the survey forms coming into the office. And and so I found out that through not directing my treatment toward GERD or correcting that I'm aware of that, and I'm sensitive to why that's occurring, and I'm trying to search for reasons where I can impact their life as a dentist. And it comes down to mouth breathing again. And let me explain all that in a couple different ways with GERD. Number one, it dries out the mucosal tissue, so the mucosal tissue lining the airway is more sensitive to acid coming in contact with it being dry, and it's lost all of its resilience to ward off such chemicals and substances, and so it's more sensitized to the acid. But it also comes. I'll get to it. I can talk about it now, but it relates with breathing and dysfunctional breathing, sleep apnea. It's all 100% of sleep apnea, of obstructive sleep apnea patients. Literature tells us all have GERD.
Fascinating.
There's a connection there that we'll review. I'd like to back up a little bit and get into why people mouth breathe. Sure. And then what do you fix first, the mouth breathing or the tongue? And so I've learned that with my initial entry into trying to help my patients who tongue thrust and move things around, causes teeth mobility to be loose, causes them to move and shift, and open up bites. And so it was very destructive to what I'm trying to correct and realign. It's just going to all change with time unless I fix the tongue. I found out that I couldn't really get to the tongue issue. I went to myofunctional therapy courses and learned about their mode of treatment and therapy with counseling and exercises with the tongue. And I tried some of them with my patients and sent them to myofunctional therapists, and with mixed bag of results. And so I said, okay, the tongue is entirely cooperative when the mouth is open. It's harder to reach the palate in an open mouth position. And so it's sure a lot easier to work with the tongue to rest on the palate when the mouth is closed. And so I could really treat two primary problems in the mouth, dry mouth and also the tongue position, by having them keep their mouth closed all the time. And that begins, daytime people can pretty much consciously be aware of and keep their lips closed. But at nighttime, all bets are off, and nobody really knows what's occurring. I've tested hundreds of my patients with double night studies of mouth breathing and nose breathing in measuring breathing disturbances and heart rate and oxygen. And it's phenomenal. The immediate night-to-night impact just by putting tape on their lips and testing them with a full night, overnight high-resolution pulse oximetry recorded testings, and then compare the two. And so all my patients became believers only when they saw the objective data. And then they would say, okay, I like this set of numbers over here better. How can I get there?
And that's
the only way.
And that's something interesting that I'd like for you to touch on too, because in the video, in your interview, you said that about 80% of your patients mouth breathe. Maybe some of my listeners right now, they're listening, they go, yeah, I don't mouth breathe, I breathe through my nose.
Exactly.
So many people I talk to, that's something I ask them, are you a mouth breather? Do you deal a lot with nasal congestion? And most, some of them say yes, but most more like, no, that's not something I do. You're saying there's a way to test. And also, can you just give us an idea of, all the patients you've seen through the years, how many people mouth breathe? Is it a common thing that people aren't aware of?
It's an extremely common thing. And I see them in the daytime, out in the waiting room or whatever in my chair. And they're mouth breathing more often than, they're breathing through their mouth really in my estimation more than a couple times an hour. They're going in that direction. It's kind of additive with time and gets into the bigger problem of mouth breathing. We'll touch on that a little bit later on here. But it's a habit that just starts, and if they're mouth breathing some of the time in the daytime, and a lot of people mouth breathe more than they think, even in the daytime, they're 100% mouth breathers at nighttime. Not all the time, and it doesn't take all the time. It just takes periodic bouts of mouth breathing, which triggers all of these dysfunctions.
Mm-hmm. Interesting. So let's revisit sleep apnea and Gerd. You said earlier that pretty much all people who have sleep apnea deal with Gerd on some level. What's the connection?
Well, the connection is with volume of breathing. It's how much air you breathe. Getting back to the basics of route of breathing, you got nose and mouth. We all know that we can breathe more air in through our mouth than our nose. And so in the nose, you have special airflow resistance sensors, which sense, and the breathing center in the brain senses, okay, you're breathing too much air in, slow down the breathing rate and slow down the rate of breathing, and therefore the volume of breathing. And so it regulates the volume of breathing pretty well. Once you're mouth breathing, it has no sensors for airflow resistance. And so you can overbreathe and not stimulate the breathing center in the brain that way. So overbreathing becomes just a habit. And as it develops into a habit, the breathing cycle, the ventilatory cycle, starts to get a little bit out of balance. And so the cycle is really a short inspiration and expiration, basically, but it's a short bout of hyperventilation and hypoventilation. And it's all, the sensors are monitoring carbon dioxide and oxygen, the blood gases, to try to keep that balanced out. The hyperventilation can't get too far going along, because then that drives down the CO2 too low, and then you got to have a longer period of holding your breath, apnea event or hypoventilation, to try to self-correct the CO2, and and then the CO2 gets too high, and the hyperventilation curve kicks in, cycle kicks in to blow it off, and so the volume of breathing increases with the hyperventilation, and that triggers longer sessions of apnea events. And so during hyperventilation, the airway pressure is different than an apneic event, which you're holding your breath longer and longer, and the negative pressure just builds up and up. In hyperventilation, you're letting it all go. And so it's the shifting, constant back and forth of the pressure changes in the airway caused by overbreathing as the primary problem, driving underbreathing too far and changing the airway pressures, which then I related to just hydraulic pumping of the stomach acids on up and out. And so it's the hydraulic pressure change of dysfunctional breathing, which is sleep apnea, and related breathing problems like that.
Yeah, that's very interesting, because I think most doctors would probably treat sleep apnea with CPAP machines. like a breathing machine, but it seems like that only treats the symptom, whereas what you're saying is treating the cause, which is mouth breathing.
Mouth breathing.
Like you said, when you mouth breathe, the CO2 levels aren't regulated, right, versus nasal breathing. So let's just say someone is, well, first off, can you talk about any tests you might run for someone who you suspect is mouth breathing? Do you have any sort of tools to tell? To tell
if they're mouth breathing?
Yeah, if they're mouth breathing.
Well, you can look clinically. You can see swollen gingiva, primarily at the front teeth. The back teeth gingiva looks okay near the saliva glands. The front gingiva is swollen, red, and just doesn't look healthy. Number one. Number two, I can look at the tongue, the side of the tongue, see the indentations, and say, that's a low tongue position. It only comes with mouth breathing. Anybody who snores, they're all mouth breathing, 95% when they're snoring. You can have some nasal snores, but primarily they're mouth snores. And so they're all, and if they're clenching at nighttime when you're asleep, that's all triggered by mouth breathing. All sleep apnea patients are mouth breathers in general. They all have dry mouth. And so dry mouth is another big indicator going on in that whole equation, leading to just compounding the whole cycle of all of the other dysfunctions occurring at the same time.
Mm-hmm. And that would make sense, if they're also experiencing acid reflux symptoms as well, because it just makes it much worse when you get regurgitation or an acid reflux attack on dry mucosal tissue. It just amplifies the symptoms.
Right.
So how do you treat someone who is mouth breathing? I understand you have created a product called LipSeal to help. How does that work?
Right. Well, with my patients, 5-6 years ago, I'd just say, the only way I know how to stop breathing through, or to make sure you're not breathing through your mouth at night, because they deny that they mouth breathe, to make sure that we exclusively breathe through your nose 100% tonight, is to put tape on your mouth. And so go to the drugstore, buy over-the-counter surgical tape, and I started sampling all of the different surgical tapes over the counter. And they're all pretty sticky. They all come back and say, wow, that's ripping off my face, and hurts my lips, stings everything, and it's not pleasant. And so I had less compliance than I liked, only because it hurt with pulling it off. And so, but they all loved the effects. They all said, man, that was the best night's sleep I ever got. And so I'd encourage them to do it more and more and more, and then retest them. I'd say, okay, do it for 3 months, and we'll retest with the subjective data with the high-resolution focus oximetry, and just look at the numbers then. And so a group of my patients I tested for about a 1.5 year time frame every 3 months with these testing, just to watch the progress, how long it takes to get there. And they had an overall collective 82% improvement with respiratory disturbance index, which is the breathing, interruption with breathing during sleep. A great improvement of oxygen. Heart rate settled down to a more normal level. So it had all of these positive effects. Also caused a lot, 80% less cycling, which is just a buildup of bigger problems during sleep apnea, really the severe one, events. And so it all had, and they're all commenting to me collectively that all of these other problems seem to go away. GERD goes away, chapped lips goes away, tartar behind the lower front teeth went away. Teeth clenching, teeth mobility, they don't do that anymore. I can monitor that with the night guard they wear at nighttime. Look at that every year and watch grinding activities in the plastic. And so I know that I've solved that problem for them when they come back and they don't have any clenching, grinding activity in that flat plain piece of plastic. So it really is. And so I'd say I'd start to encourage all my patients, to, and they all seem to have some level of problem with sleep problems, breathing problems, nasal congestion, and they're all basically adults, and so I can't go back in and try to redirect growth. But if I can at least get their mouth closed and then work with the tongue. Then I can work with the tongue after I have the mouth closed predictably.
Yeah,
then
and talk a little bit more about the tongue, if you would.
Okay.
Are there tongue exercises usually recommend to patients that they do, and how do you work with the tongue?
I work with the tongue. I try to simplify it to something that they'll do. I sent both my grandkids to a highly well-known mouthfunctional therapist in Denver, nearby where I live, and she worked with them and taught them these things. At their ages at the time 4 and 5 or 6, and they learned, and they loved to show off their new tongue tricks for me. But it was not. They didn't maintain it beyond the initial month or two, and so that became discouraging for me. Also, adult patients I'd send, and they said, it was nice to learn and know, but they didn't. Nobody really continued using it, and so it's not doing any good. So I tried to simplify all of the different exercises that they're taught into one basic one that they might do, and that just I call it the tongue push-up, and I just have them place the tip of the tongue on the anterior palate and push up with pressure on the palate, and hold it there for a count of 10. Relax, do another one, do 10 of those, and that's one set, and then do 5 sets a day. And it's remarkable. Patients would come back in after doing this 6, 8 weeks or so, and they would comment to me, unsolicited, say, wow, that tongue exercise you taught me, I really like that. I noticed the difference. I'm sleeping better. It's really pulling the tongue out of the airway and breathing better, and I'm just, I feel better. I wake up more alert, and so I could only work with the tongue after I worked with the lips, and using tape is the only way I knew how to do that. So I tried a lot of different tapes, and they were all still too sticky over the counter. And my patients we'd find the best one out there, and even that still had a common complaint. It hurts to pull it off. When can I quit using this? And I said, okay, well, I worked with 3M at that point, and I said, okay, they're all 3M tapes, and said, this is the problem with my patients. I like to put the tape on the lips, skin of the lips, and so so I got looking into the makeup of the skin of the lips. It's a semi-moist skin. Your face skin is dry skin. Mucosal tissue is moist tissue, and so it's a semi-moist skin, the skin of the lip, skin itself. And so it reacts a little bit differently. And so I found one particular adhesive stickiness and also conformability of how it flows comfortably around the contour changes of the lips. And I said, this is it. And I reshaped it from a block rectangular piece strip across the face. And just to cover basically majority covers just the skin of the lips. And it is super effective with restraining lip opening up during sleep. But it's gentle enough to wake up and just open, and it pops open. And I do like tapes that cover all of the lips. Many patients would report just using 3/4 length piece, and they weren't responding normally. And so I said, show me what you do. Come in the chair and show me what you do. And then things still blow through that little corner opening of the lips. And so that's being stimulated by this overall problem that they have is over breathing in general. And so their body sensors saying, I want to breathe more air than this silly tape is allowing me to do. And so they find a way to cheat during sleep to get more volume of air, just because the brain centers have been conditioned to like a bigger volume of breathing. But it's detrimental to your health in many regards. I learned a lot about hyperventilation and the problem with overbreathing from Patrick McEwen, and he teaches the Buteyko breathing method to try to. Sole purpose is to reduce the volume of your air breathing, and that begins with taping the lips and then slowing that one down, and you can start working with the overbreathing problem.
Have you encountered any of your patients who used LipSeal, your product? And by the way, if you want to find out more about LipSeal, you can go to Dr. Seaman's website, LipSealTape.com. That's LipSeal, SEAL, tape.com. But I've just talked to quite a few people who actually have issues breathing through their nose, and that's why, when you talk and you say to them, hey, have you ever tried keeping your mouth shut or using some sleep aids to help you do that? They say, oh, no, I can't breathe through my nose. That wouldn't be a good idea. Are there any things you would recommend for someone who can't breathe through their nose as easily? Personally, for me, I actually have a deviated septum on my left nostril, so I found doing a nasal rinse like a neti pot quite beneficial for me, but there may be people out there who may not feel comfortable using LipSeal tape or any other sleeping aid. Are there any things you would recommend for those people?
Right. Neti pot is excellent. A lot of the saline rinses, nasal saline rinses in general are all super effective. It's one extra thing. My patients say, oh gosh, one more thing on the list I got to do to go to bed, Going to sleep was becoming more of an effort than it was worth. And so I try to work with them and work with congestion. And so I found that congestion, once you can start breathing through your nose with tape on your lips, it's a lot harder to become congested unless you take the tape off, and then within a minute you'll become congested with the drying effect. But you gotta break it up first, and so you can breathe relaxed breathing through your nose without congestion. The rinses help quite a bit. Patrick McEwen has an exercise in his exercise program to decongest the nose, which is highly effective. And it involves just breath holding with body swaying for as long as you can hold your breath. And by doing that, then you breathe in, inspire through your nose at the end of that very slowly, and you're taking in nitric oxide, which has been produced in the last 30 seconds or so, and that causes vasodilation and immediately opens up the airway.
And something else I want to ask you about, Dr. Seaman, is why do you think this information isn't too well known among patients out there? It seems like, I mean, at least for me, none of the dentists or doctors that I've been to ever told me that mouth breathing could be associated with breathing issues, with a dry mouth, a dry throat, or acid reflux. Is this knowledge about mouth breathing that it can cause all these issues? Is this something that's widely known in the medical community?
They're becoming more and more aware of it. I'm out on the lecture circuit preaching to dentists, the benefits of it and how to do it, how to implement a program in your office. Really, it comes through the dental hygiene section. I call it just preventive dentistry, help out with their overall dental factors by teaching them how to breathe more effectively through their nose. And so it hasn't been widely practiced, shall I say, and it's rarely taught in dental schools. It's where it should be begun. Dentists, during their more formative years of dental knowledge is taught, but it's not there yet. It's not in the curriculum, and it's not in usage very much. And so it's sad for me to see. I've seen wondrous effects with my hundreds of patients and they all. There are some that like the medical model of getting fixed up and don't want to take the effort to take their own physiology in their own control, and they rely on the medical system, and so they kind of resent me being so insistent upon what I know would be helpful for them. So it's going to take a period of time and really in my mind, coming from the public, once the public goes and starts demanding their patients to teach them about, go ask your dentist, and especially orthodontist if you have any kids out there, what they're going to do about your kids' mouth breathing and what they're going to do about the tongue thrusting. And you'll get a blank stare. They may know what to do, but they don't want to go there because actually there's no money in teaching somebody how to breathe, and it corrects all other problems anyway. So I say that it's counterproductive for the dentist, and it's just reality. And I try to help my patients, and really by helping them, they're going to have less dental problems and less breakdown of what I do for them, and so it's all good, and they appreciate it.
You mentioned earlier that you are a Buteyko instructor. Can you tell us what Buteyko is and how breathing the correct way can help with acid reflux and can help with preventing mouth breathing?
Right. Buteyko is named after Dr. Buteyko from Russia in the latter half of the last century. And so he worked with his patients in Russia. He noticed as a physician that in intensive care units that the people that came in and were breathing chronically through their mouth tended not to leave the hospital, and those that were nose breathers tended to get well, just as a casual observation. So he spent the rest of his life kind of going down that path and learning the differences and learning about the Bohr effect and carbon dioxide, oxygen balance, and everything else. And so he developed a series of exercises that his son, still over in Russia, teaches over there. But Patrick was fortunate enough to be in London at the time, and he was a severe asthmatic. And so he was getting no help from the medical system at the time, and he took it on his own to go over and study with Dr. Buteyko in, I think, about 2002 and he learned the exercises, and it worked fantastically for him. And he said, I'm a believer in this, and he quit his business. He was a businessman in downtown London. He quit his real job and started just to help other asthmatics at the beginning with learning how to breathe. And it all begins with taping up the lips. Buteyko used to sell tape also, but it was really, really harsh to almost like duct tape, and so very effective in Russia. It worked. And
that would hurt a lot.
Yeah,
I would imagine.
Yeah. So, the main point of using something that restrains your lips from falling open, the facial chin straps and things like that, they close the jaw structurally, but they don't do much with stopping the urge, the necessity to open up the lips to even breathe through the teeth if you have a bad enough hyperventilation problem. So, and then it gets after you work with the tape, then it gets into Patrick's developed a wonderful program to educate people with the physiology of what's occurring and why, and also with specific guided, coached exercises to help reset the breathing center patterns and stimulus to overbreathing. A wonderful program. So my wife and I both became instructors, learned the technique and the method of conducting programs and with that, with the Buteyko breathing method. And so the interest has to come from the public and people. Podcasts like you and your services out there are just wonderful with getting the word out with people that want to take charge of their own destiny. And congratulations to you and what you're doing.
Well, thank you so much. I appreciate that. It certainly has been a journey, these years, just suffering from LPR for so long and not getting answers. I just had to make a decision to kind of take it in my own hands and do my own research. And yeah, very glad to have found Dr. Mew and also you as well. So for our listeners who have acid reflux, let's just do sort of kind of three things they can take away from this podcast. So number one, if they suspect their mouth breathing, and again, the telltale signs are, waking up with maybe a sore throat, dry mouth, chapped lips, and I was just kind of smiling when you were naming these symptoms because I used to get these symptoms all the time in high school, and now just thinking back on it, I'm saying to myself that totally makes sense. I was mouth breathing, and that would explain why I would lose my voice as well. So getting chapped lips, maybe being hoarse in the morning,
right?
And
Snoring.
Snoring, okay, and sleep apnea. Those are all
Apnea.
things that could be caused by mouth breathing.
Congestion at nighttime.
Congestion.
And bad morning breath.
Bad morning
breath
breath.
in the morning.
Okay. And
That's all from mouth breathing.
Gotcha. And the second thing they can maybe do is try your tongue exercises, what you call tongue push-ups.
Right.
And that involves putting the tongue, the tip of the tongue on the hard palate and pressing.
Right.
Okay. And the idea is that that will sort of train the tongue to cling to the roof of the mouth.
Well,
And
it'll redevelop the lifter muscles of the tongue at the base of the tongue.
I see.
Genioglossus and all of the glossus muscles. They're the suspension muscles. They hold the tongue up. And they need a certain muscle tone, like all muscle tone. That's why you can sit there in a chair without collapsing over, You have muscle tone holding you up. Same thing with the tongue. It just has lost its muscle tone, and it can be redeveloped pretty simply and very effectively. Only when the mouth is closed. And so you got to start with the mouth closed position to begin with.
Gotcha. Very, very interesting. Guys, if you want to learn more about Dr. Seaman's product, LipSeal, be sure to go to his website to find out more. LipSealTape.com. That's LipSeal, SEAL, tape.com. And if you want to visit Dr. Seaman, you're in Colorado, you're located near Silverthorne, Colorado, feel free to go to his website to book an appointment with him and find out more about Dr. Frank Seaman, one of the top prosthodontists in Colorado Springs. His website is anaturalsmile.com. That's anaturalsmile.com. Well, Dr. Seaman, it's been an honor and a pleasure having you on the podcast today. Thank you so much for coming on Gerd Talk, and I hope to have you back again soon.
I appreciate it. Yeah, thank you. I enjoy talking this issue and subject as much as I can. So any other time, I'd be happy to come back.
Definitely. Would love for you to come back, Dr. Seaman. And once again, thank you so much for your time.
Thank you.
That does it for today's podcast. I hope you enjoyed this podcast as much as I enjoyed interviewing Dr. Frank Seaman. If you want to read more about mouth breathing and find out more, you can always go to my blog, gerdwise.com. That's GERDwise.com. Just go to the search bar on the right-hand side, type in mouth breathing, and it's going to pull up a couple articles on mouth breathing for you to study further. Once again, if you are interested in trying out Dr. Seaman's product, LipSeal, to find out if that's going to help your sore throat and to find out if you are a mouth breather, just go to LipSealTape.com. That's LipSeal.com. If you want to follow me, I'm on Facebook, Pinterest, and Twitter. Just type in GerdWise. That's GERDwise.com. This is Stu saying, reminding you once again to never give up and never lose hope.